This panel is presented by Methodist Healthcare Ministries of South Texas. The corporate sponsors and donors, as you've heard today, underwrite this event. They play no role in determining the panel's content, panelist, or line of questioning. Like the other panels, we will have 50 minutes with the last 10 to 15 minutes of that period for audience Q&A. As you know, you can text your questions to 512-692-0689, or of course tweet using the hashtag AskTrib. Long day, last panel. Seated next to me to introduce my panelist up here is Deborah Flores. Susan Rushing. Pardon me, I asked you right before when we introduced. CEO of Burke, a mental health and developmental disability services provider in a 12-county region in East Texas. She's worked in various roles at Burke since 1988 and as chief executive officer since 1990, where she oversees some 400 employees. Ms. Rushing received a master's in psychology and is trained in cognitive behavioral therapy, among other social services and crisis intervention. Seated next to her is Ms. Debra Flores. She is director of the West Texas Area Health Education Center at the Texas Tech University Health Science Center F. Marie Hall Institute for Rural and Community Health. Say that 5 times fast. Where she's been instrumental in the implementation of community health care or health workers in West Texas. She's a certified community health worker instructor and has worked as a licensed vocational nurse. Seated next to her is State Representative J.D. Sheffield, first elected to the Texas House in 2012. State Representative Sheffield represents Gatesville and the people of District 59, an 8-county area that stretches west of I-35 between Dallas and Austin. The only family practice and rural physician in the Texas legislature, Dr. Sheffield served on the Public Health and Appropriations Article 2 House committees, where he's worked to improve rural health care and health care for all Texans. And last but not least, John Henderson is president and CEO of the Texas Organization of Rural and Community Hospitals. He served as CEO at Childress Regional Medical Center, his hometown hospital, for some 16 years. There he oversaw a 39-bed hospital operated by a county hospital district where patients travel as far as 70 miles for care. With that, we will get started. So, going back to the poll that kind of has framed the day large in part that we did going into this, the future of rural Texas, when it comes to medical matters, as you heard probably earlier this morning, 77% gave excellent and good marks for access to quality health care, and strong majorities did the same for access to medical care and emergencies and to health care services for the elderly. Only 41% gave high ratings for access to mental health services, and about a quarter did so for access to drug abuse and addiction treatment. So let's go overview some of the challenges, that again overlap with the topics we've been discussing today. But I guess talk about some of the obstacles to healthcare, to access in the rural areas. Mr. Henderson?
Sure, you can look at a state map and see health provider shortage areas that show physician shortages and even counties with no physician. Then the only map that looks worse than that is mental health service provider shortage area, which is basically a map of rural Texas. We count 19 rural hospitals that have closed since 2013, which is double any other state. Tennessee has had 8 in the same time frame. And so even though people are proud of the services they have generally in that poll, we're starting to see some of the locally available services fall down.
Well, and in fact, I understand it, and I believe you wrote an article for Trib Talk, our op-ed site, citing the fact that Texas leads the nation in hospital closures. Dr. Flores, how much does provider and teacher shortages factor into that?
Yes, it factors in quite a bit. We have a huge problem in rural communities with provider shortages. That is one of, it was interesting as I was listening to the other panels that did not really come up as an issue. Because that's what we're seeing. We had a discussion a couple of weeks ago in Abilene. We brought together some administrators from the rural hospitals that are interested in recruiting providers into their communities and trying to identify strategies to do so. The percentage that you counted as far as not having a problem with access probably live in urban communities. The rest live in rural communities where there is problem to access. There's no providers, as John said. And then the ones that are available are several 200 miles away. So it is definitely a problem. In addition to that, these rural communities are also having a problem with educators, teachers. There's a very huge problem with that. With West Texas AHEC, one of my centers is in Permian Basin. We recently hired a community-based educator from Midland, and she was a teacher. But she had 60 students in her class, some of them sitting on the floor, and therefore left the teaching profession because of the problems they were having in education, which is really sad, because our children are our future. And as they grow, without them, we really have to focus on education and healthcare. We have to have healthy children, educated children.
Dr. Sheffield, you cite, and in our reporting have cited declining Medicaid reimbursements across the board as a huge contributing factor. How so, and did the state make a mistake when it declined Medicaid expansion at the start of Obamacare? I know that's a politically heated issue.
Where'd you say the door is? No, I think we're all on the same side in here, and that's to get better health care to the rural areas. Rural hospitals, by their location, have a disproportionate share of no health insurance, Medicare, Medicaid, the poor and the elderly. So we're already starting, in a way, behind the 8 ball. Second, rural hospitals rarely have the procedures that the urban hospitals do that bring in such revenue when you've got an orthopedic surgeon who does 4 shoulders in one morning and cardiologists who put in stents all day long. We don't have that revenue source. So we are more and more dependent on Medicare and Medicaid, which Medicaid doesn't even cover the cost. So when the sequestration came along and cut another 2%, we community access model getting 100%, now we're getting 99%, so we're still below. Now, okay, we could talk the whole 50 minutes about ACA and what happened in the legislature that year. The main point I would like to get across to you is how highly charged politically that was, and of course you know how highly charged it was, but it was even more highly charged on the Texas House floor. That has some part to do with the rise of the far right, some part to do with then Governor Rick Perry, and still some part to do with not liking Washington. So anytime one of us said something about Obamacare, which is the phrase used, instantly you got fingers pointed at you and said, that person's a liberal. They're not a true Republican. And therefore, you're opening yourself up for a race in your primary next time, which some of us, the healthcare folks, are still prepared to do that. But when Dr. John Zerwas came before the Texas House with a bill stating, we're not going to accept ACA as is, but this bill would allow us to go to Washington and negotiate with CMS to get that same amount of funds brought back to Texas and used as we think best for Texas. Now, I think that was a fine idea. He wasn't even allowed to get a vote on that bill because anything touching ACA at that time was just pure dynamite. So you'll see now in studies across the country, in those states that had accepted those funds, they now have more people, more patients getting some type of third-party coverage than they did before. So they're getting something, whereas before they would have got nothing financially. So something that looked good in the short run politically, I think was not good in the long run for patients.
And a lot of that is preventative care, right, which brings costs down. Is that what you see, Ms. Rushing? You on? Yeah, you're on.
Yes, and people, providers such as myself and our organization, serving people primarily with severe and persistent mental illness, typically, only 1/3 of the people that we serve now have Medicaid. The rest are uninsured. And it makes it very difficult to serve the people that are out there who need that level of care. Another headwind that we face is that the rates for psychiatry in Medicaid are lower than those for other professions, and that people who do have health coverage, only recently was mental health given parity with physical health care. And again, that's a struggle to get that into effect, although it is the law. So we see lower payments, fewer people with coverage, and it makes it hard to meet the demands out there for mental health coverage and for substance use treatment. It's a big deal to us. Things changed in 2011 with the 1115 transformation waiver here in Texas. Behavioral health was made part of that. And what that meant for providers like mine was that we had access to some of these dollars. And with the 1115 waiver dollars, Burke was able to more than double the number of people that we served in mental health services because we had funding now for a broader bandwidth, more capacity. And we went from an organization that had a waiting list of over 500 seriously mentally ill people to a place now where if you need us, you can call us, you can come in the same day and get help. And I think that's what we want for people with mental illness. If you or somebody you loved was struggling with a severe mental illness, wouldn't you want them to get good care quickly? And I think that's what we're getting to now in Texas with the 1115 waiver. The downside is that in 2021, $3 billion of that money goes away. And in 2022, the other $3 billion goes away. But Texas has an opportunity to use the ending of this waiver to negotiate a new deal with the federal government and address some of the issues that you have raised about coverage.
Well, we could probably, again, like so many have said, we could spend the 50 minutes focusing on the shortcomings of healthcare in the rural areas, but if anything, it's forced, limited resources, doing more with less, and innovative ways to address these issues. Mr. Henderson, what do you see as some of the innovative ways that they're addressing these?
Well, when Comptroller Hager was speaking, he said he would like high commodity prices and perfect weather. And I was thinking about a story that a local cotton farmer told me once, which was his best cotton crops didn't happen when you got perfect weather and rain at the right time. His best cotton crops happened when the plant had to grow and stretch a little bit and had some tough situations in addition to the timely rain. And that, that's true in my life too. We do our best work under difficult circumstances. And so I see opportunities to innovate. I see opportunities to redefine the way we provide access to care, because that's really what ensuring health care is about, is that people have access, that your zip code doesn't determine your health outcome or life expectancy, and that there are no throwaway Texans. But we have a tendency, it's not all elected officials, there's enough blame to go around among the physician community and the provider community. We tend to hang on to what we've always been instead of stretching and trying to meet the patient need in new and innovative ways. An example with regard to mental health is I was talking to an MD psychiatrist from Amarillo, and I said, through telemedicine, what can't you do that you can do when you're face-to-face like this? And his answer was nothing. And there are different specialties. Dermatology is procedural. When I'm having a heart attack, I don't want an app or to FaceTime a cardiologist. I want a team of people to care for me. But there are ways that I think telemedicine becomes a game changer, particularly with regard to access to specialty care in rural Texas.
Well, it may be coupled with, being able to do labs locally and have that person look at it and couple that with telemedicine.
Yeah, that's
Dr. Flores, lots of technological advances, as we talked about, and one that even Governor Abbott recognized in the wake of the Santa Fe shooting was the Telemedicine Wellness Intervention Triage and Referral Project, again, say that 5 times fast, by Texas Tech University Health Sciences Center. Explain how that tool could possibly be implemented statewide, as the governor has alluded to possibly advocating for.
Well, that program definitely has a lot of potential. It has been beneficial in the schools that it has been implemented in. There's, of course, a lot of mental health issues in our youth, and coupled with the opioid problem in rural communities, that only makes it worse. And so, you know, using that particular tool to save lives, to prevent school shootings, to prevent a lot of you know, possibly tragedies in the communities is really important. However, we still run into the problem of not having enough providers, not having enough psychologists, psychiatrists to be on the other end of that telemedicine equipment side to take those calls and to refer those students to. So,
Explain for people who aren't familiar, how does the program work, and how are school districts using this tool?
so we have licensed professional counselors that are coupled with a psychologist, and we get referrals from the schools. And these referrals are from really students that are identified to have issues, behavioral and other issues that are identified by their school counselors, principals, teachers, nurses. And of course, some of these are small schools, so they may not have all of the above, but at least one. And so the LPCs do an assessment of the students. They go out to the schools, do an assessment, meet with the parents, and then they are referred to a psychologist for treatment if necessary. Unfortunately, there's only, I believe, 3 visits that are incorporated. So again, because of the shortages of providers, that kind of it limits, but I believe it still, you know, impacts the communities quite a bit.
The fact that it's on the governor's radar could bode well for funding, possibly.
Yes, and I know that they're still working that out. I'm not sure what's going to happen there, but we're doing the best we can with what we have currently, the budget that we do have. There are currently 3 LPCs in the South Plains region, Lubbock area, trying to take care of that problem.
Mr. Henderson, did you want to add something?
Well, she mentioned the difficulties of recruiting, and let me just say, as someone who recently moved from a small town to the city for work reasons, there is a rural recruiting path and story to tell. I'm still mad about what it cost to buy a house in Williamson County relative to the Panhandle of Texas. I really miss my 3-minute commute and get angry when I'm stuck in traffic. I think for the right kind of person that appreciates a rural quality of life and likes the pace and wants to know their family, you know, they also say that you recruit the spouse because work's work, and if their spouse isn't within 100 miles of a Nordstrom's, that's a problem. And I would say that maybe that's not the right fit for your community, but also an Amazon Prime account is a remarkable thing for someone who lives in rural Texas, and you can overcome some of those things that are rural challenges. And I think when you get high-speed internet and things like that figured out, there is an appeal to rural Texas that we just haven't realized or achieved yet, is all I wanted to add to Dr. Flores' comments.
Thank you, and that is very true, and that is those are the types of strategies that we're looking into to recruit those individuals. And grow your own, again, comes up as important, so that's why it's extra important to have teachers so that we can start growing our own very, very early.
Still, there are shortages, and Ms. Rushing, you talk about how rural workers, as a result, are resourceful, as all communities who are strapped for resources are. What are some unique strengths and opportunities that rural providers bring to the table?
I think it's a willingness to collaborate and to work together. In our area, back in 2008, we didn't have much of a crisis system, and it was a real burden on our hospitals and our law enforcement. But when we began meeting with our county officials and our local hospitals and sitting at the table, we were able to come up with some ways that we could make things better. And through that, we established the first rural freestanding psychiatric emergency room that was staffed by psychiatrists through telemedicine. And it reduced hospitalizations from our area by 75%. And we were able to take care of people in crisis in that way in our own 12 counties. And that freed up law enforcement, and it helped decompress our local emergency rooms. We recently commissioned a study on the hospital cost avoidance of that program, and the results are showing conservatively a $2.5 to $3 million savings for our local hospitals for that program. So I think there's some ways to do this. We just have to come together, because what we did benefited our hospitals, benefited our law enforcement, but that really benefits our community.
Dr. Sheffield, one solution you see is just a simple return to primary care, including when it comes to mental health and substance abuse. Kind of get out of the specialties and subspecialties business?
Let me start back at the first of how you get to be a doctor. And first, you have to get accepted into medical school, and then medical school and residency. Now, there's no doubt on any of the charts that our biggest shortage in the future in healthcare will be primary care, and that is mainly family practice. So my point when I speak with my colleagues on this is that starts when you're first interviewing that candidate for medical school. What field do they want to go into? And do they have what it takes? I'm a DO, osteopathic. About 50% of our class went into family practice. MD schools, 10% go into family practice. So I would tell these folks when they're sitting there in the chair, what are you in it for? Okay. What kind of practice are you looking for? And third, by the time you get to being a physician, the money's not going to be there anymore. Okay. We just can't withstand this high cost like we are. So it starts of picking students who want to go into family practice first, and then we have to, I was trying to think of a word, encourage, coerce, force. Incentivize, that's a good way. Yes, thank you for that. Medical schools, and especially the residencies, to refocus on primary care and away from specialty and subspecialty. Because I bet if you went back to your areas and you started calling, you'd have a harder time getting into a family practice doctor than you would your cardiologist or orthopedist. So it all starts with who we're selecting for medical school and what their plans are for a practice.
So no state solution there as far as, again, like we've been talking about throughout the day, to encourage this person or that type person to move to a community, incentivized by saying you served so long in a certain community of a certain size, you know, we'll pay your loans or whatnot?
You've hit upon a very good thing, the physician loan repayment. In my experience over 25 years, that is the best tool to entice someone to a rural area. And then they settle down, they get roots, and they realize, I like living in a small town, in a rural area. And also, they like the broad scope of practice there. It makes them feel like they're giving more back to their patients, more fulfillment. Now, we're going to have a little trouble with the legislature here, because this current budget, they cut the family medicine residencies by 40%, and they cut physician loan repayment by 25%. So we have got to work to restore those funds and overall just redirect our focus back to primary care.
Will that be a priority of yours in the coming session as far as restoring those cuts?
Oh, absolutely.
Did you want to add?
Well, what they're describing to me is the future of rural health care, where we're actually trying to play offense instead of defense, and you're dealing with mental health issues before they become catastrophic. You're playing offense in the clinic setting with primary care, home health, things of that nature, rather than ending up with the big, large, catastrophic hospital claim. And that's the future. You know, the ER is not only the most expensive place to provide care. A successful ER visit is when the patient walks out of the ER alive. They aren't going to deal with your diabetes and your chronic condition and all the stuff that's going to turn into problems down the road the way they do in Dr. Sheffield's clinic in Copperas Cove. So that's better for the system globally as well, because you're saving system dollars in the long run.
Dr. Flores, how can state officials and federal partners work together to stabilize healthcare finance or healthcare costs?
That is a really good question. But I think that, you know, our representatives, at least the ones that represent West Texas, have been active in coming out. We had some come out to our Rural Health Symposium a couple of weeks ago. We've gone out to talk to them in the rural communities and educate them about what it will take to continue to feed the pipeline. We need to continue to do that, and I think by increasing awareness and providing education, we also probably flood our representatives from AHEC with a lot of success stories about our programs and how they have impacted students from secondary school and help them identify a healthcare career. It doesn't have to be MD or a nurse. It can be a PT, OT, psychologist, LPC, that, you know, impact them that way, let them become interested, and then feed that pipeline. And I think they, the response that we've gotten is that they appreciate that. They sometimes have other priorities and they overlook the healthcare side of things, but we've gotten good responses, and I hope that they are able to increase the funds of those residency programs, because that's going to be real impactful in a very detrimental way if they're not.
Well, personalizing that money and the results of that money is key, right, Dr. Sheffield, to furthering that budget as far as showing how the money was spent and maybe what benefited as a result, or what they got for their money?
Yes, that would help a lot. We need to touch on the issue of medical insurance companies at this point, because we're talking about healthcare shortages, but what funds that is revenue, and a lot of that is medical insurance companies taking out Medicare and Medicaid. I would assume most of us here in the rural areas, when you're trying to get your group policies, you may have one or two insurance companies who put in a bid. That's not real competition. And there's a whole lot of issues in medical insurance that I think they're going to have to be forced to change, and then we will have a better revenue stream for all across the board.
Is there the political will to do that, say in the coming session?
The political will exists when you have sufficient education about these issues. One thing that surprised me when I got to the legislature, being a doctor, I wanted to go down there for health care. And it was that health care was not on the burning forefront at that time. What do you see in the headlines mostly? Lack of primary care or Second Amendment gun rights. And what are they talking about a lot? Funding for rural hospitals or abortion. So it's that they don't have the knowledge about it. But when you start talking with them, and we've done a very good job in the last few years getting more and more about, okay, here's how healthcare impacts your district. Here's how the lack of healthcare hurts your district. And here's the few things you can do that can make a big difference, especially for rural, but it also benefits the urban hospitals also. So primarily, it's education first. And then when they understand it more, they're more eager to pass legislation about it.
That's very well said, and we're learning to talk about the closure crisis in terms of economic development, like the last panel discussed. There's a story out of Tennessee where a rural hospital closed, and a local family practice physician said, I didn't realize it, but the hospital was actually holding this community up. There's a study in rural Georgia where a hospital closed, and they went back 2 years later, and it wasn't just the hospital, the pharmacy had closed, and then the bank closed, and then the only grocery store in the county closed. You know, the hospital in Bowie closed, and the economic development coordinator there, named is Janice Crowley, says that the following year their sales tax revenue dipped by a third, and then the second year it dipped by another third, and the school enrollment fell, which drives the state payment, and people didn't locate to Bowie, and then houses that were on the market the day that the hospital closed are still for sale. And so there's this devastating, snowballing economic impact of not having local access to health care.
And confirmation that all the topics we've talked about today are so intertwined in these communities. Real quick, Dr. Sheffield and then Ms. Rushing.
Another angle on this is when I'm talking with people about rural hospitals and hospitals in general, but especially my rural counterparts, I tell them, when you go to these small towns, the school and the hospital are going to be your two biggest employers. And when we're trying to recruit young couples with kids, first question they'll ask is, how good are your schools? We're all trying to get the retirees, and they do want to move to rural areas. Their first question is, how good is your health care facilities? So if we don't have good answers for those two questions, it's hard to land them.
Ms. Rushing.
And the cost of not providing timely mental health care, among those are, the burdens tend to fall on our local hospitals, which just exacerbate problems there, and also on law enforcement. And those are not where you want people who need help. So I think there's a downside. And when the sheriffs came to town, to Austin, in support of mental health care, those were voices that were heard, and we had good results from that.
Of course, we are just a few weeks out from the legislature, and we're just a few days out from the midterm elections. And looking at the map, Mr. Henderson, you speak of the rural parts of the state that keep Texas red. Elected officials maybe haven't done too much to earn those votes. How do you see it?
I don't think that's exactly the way I said it, maybe so. But I asked this question last night, and it's actually from Bosque County, which is neighboring to Coryell, where Ted Cruz carried that county by 80%, but local taxpayers voted a property tax for a hospital district, and I'm just having trouble in my mind reconciling those results, or trying to think about what kind of conversation that leads to when it comes to healthcare, or maybe more precisely, what has Senator Cruz done to earn that vote or to assure that vote next cycle? And I'm not sure that I know the answer, but it's fascinating to me because Texas is red because of rural Texas, not because of urban or suburban Texas.
Dr. Sheffield, you're nodding.
Exactly right. Exactly right. The first session I was down there in some of the introductory, the veteran Republicans told us, new guys, said, you think your fights are going to be with the Democrats. You're wrong. You rural Republicans are going to be fighting the big city Republicans more than you will the Democrats. And you're going to find that the rural Democrats and the rural Republicans have far more in common than they have in differences. And that has proven to be true.
Where have you seen alignment on those issues? I mean, just all the issues we've been talking about today? Similar interests, similar constituencies?
Similar. All rural areas, all districts, they want good schools, they want good health care, they want good roads. We'd love to have broadband access.
Yes.
We want more control over our water. There was literally almost it was a word fight. It wasn't a fight. Y'all saw the fight the last day of the session. That was something. And at one mic was all of the reps from Dallas. At the other mic, mostly Republicans. At the other mic was all the reps from East Texas, where that water was coming from. And it was Republicans and Democrats. And I thought, there's a picture worth 1,000 words. The country guys will stand together against the big city folks, but sometimes we're getting outvoted.
How many, and I haven't had a chance, normally before session at the Tribune, our demographics reporter will break down the makeup of the coming legislature and look at who's coming in and where they represent. Do you have any idea if rural is more represented this time around, or, of course, based on where there were elections? Not where there were.
Before, it was 95 Republicans, 55 Democrats out of 150 seats. That number 150, by the way, in the Constitution came from the book of Psalms having 150 chapters. That's where they got it from. And the Senate has 31 senators, 31 chapters in the book of Proverbs. So I did a head count last session. You take the biggest 6 counties, all those reps there, you're looking between 65 to 70 reps in just 6 counties. And so a lot of the rest of them have 3 or 4 counties. Now you get to the rural guys, I was counting 4 counties and more. 15, 18, 20 out of 150. So our ability to work together across party lines, very important when it comes to rural issues.
We have about 5 minutes until we're going to go to the audience questions. Again, text using the hashtag AskTrib, or just text AskTrib to 512-692-0689. I think with Dr. Sheffield on this panel, both his medical background and, of course, being a member of the legislature, I asked it this morning in education. My colleague Brandon Formby asked it in another panel. But what are your primary, your top 3, if anything, healthcare focused matters, legislation pieces going into the next session? Mr. Henderson, we'll start at the end.
Well, there's a significant Medicaid underpayment since the state went from traditional Medicaid to managed care. We estimate that to be about $60 million, and we're going to be asking for it. It's hard to succeed with that, but that's number one. The state's made progress with regard to mental health and telemedicine,
Yes.
but we'd like to see more just to shore up that foundation where we can innovate from. And the third is around workforce recruitment and retention.
Dr. Sheffield?
Our primary focus with a lot of our bills is going to be on the cost of health care. How do we start driving that down? And a popular phrase is to bend the curve. Well, we don't want to start bending the curve. We want to drive it down because it's a significant hindrance to small businesses in rural Texas. So the cost of health care, and again, starting this swing back towards primary care. That is a lot harder to do than to talk about it. It's going to take several years and a lot of force to get that done, but I think it's vital both for Texas and for our cost of health care to get that done. And third is to keep shoring up when we get these gains, like in mental health, to keep certain that we keep that going with the funding and we don't lose it once we've got it.
Dr. Flores?
Well, of course, workforce is real important. Mental health is a top priority. And then one of the things I don't think, well, it may have been mentioned, is the poverty level that is occurring in the rural communities, which it's kind of like a snowball effect on how it affects everything else. So addressing that is probably not a priority right now for legislators, and I don't know how that would happen, but I certainly think, and maybe it has to do with education and the lack thereof in rural communities, the teachers that are leaving the profession, and the children are left uneducated,
Thank you. Ms. Rushy?
and therefore leads to poverty, sorry.
Thank you. Ms. Rushy?
I agree that sustaining the gains we've made in mental health and ensuring the financial stability of that going forward is very important, as well as adding to the services we can provide to those who need substance abuse treatment.
Thank you. And with that, I'm going to go to my colleague, Brandon Formby, who has the audience questions.
Our first one comes from Luciano at the Texas Tech University Health Science Center. What plans does Texas have to fight mental health issues, specifically in children?
May I?
Yes.
We're doing a lot on that front. We are right now undergoing a lot of initiative to provide mental health first aid training to people in schools, teachers, educators, lunch ladies, bus drivers, so they know what to look for so we can intervene early with kids who need help. Another thing that we're doing, and I know at Burke we have this program, is something called First Psychosis, Early Psychosis, where we focus on services to young people who are having their first psychotic break. Usually that happens between the ages of 16 and 22, so high school, college age kids. If you can, the research has shown that if you can intervene early With education, the right dosage of medication, and supports, you can change the trajectory for people with that illness. And that's been very successful, and I think Texas is trying to take that to scale across the state. Those are a couple of things that we're doing.
You mentioned mental health first aid, and I did an event a few years ago. I was talking to some people about here, where afterwards it was all on mental health, and we talked about mental health first aid, and 3 guidance counselors kind of ambushed me at the end and said, you didn't mention the guidance counselor, and just what role they might play, and if, there's funding. I know that was maybe one of Governor Abbott's 40-point plan in the wake of the Santa Fe shooting, but what about, yes, it's great to have several people trained, but what about fostering that relationship between the guidance counselor and the student?
I think we have a lot to do there and make inroads with schools, but let's let counselors be counselors. I would say that.
I think the Twitter program is making a lot of inroads in the crisis side of things, but I do believe we need a lot of prevention side of things. And that is where we're lacking. We don't have anybody out there that's doing any prevention programs. The ones that are out there are shortly funded and therefore come and go. And so I think we need to focus a lot on the prevention side and get those types of programs funded.
Brandon?
We had one question early on about asking about incentive programs that you kind of got at, Representative Sheffield. So I'm going to kind of ask it this way. If incentive programs have been cut, what political obstacles do you see in restoring them, and what can Texans do to get their lawmakers to prioritize those programs?
First thing, doctors make lousy politicians. We love doing health care, we love our patients, and like a lot of folks, we'll go vote when it's time to vote, but otherwise getting involved is just not something our nature and character. That is changing. It's having to change, because if voices like ours are not down in Austin, there's no one speaking for patients. Everyone here on this panel is one of those voices. Now, another issue is a lot of the leadership, governor, lieutenant governor, speaker of the House, if they make that a priority, that's like putting grease on the tracks to get something done. It'll go through a lot easier. Now, pointing out one thing that can be a reverse, a lot of the reasons we got so much health care for mental health last time was because of all of the mass shootings, and because those had made the headlines. So when things like that start making headlines, then you start getting the attention of leadership. I'm just sorry it had to go that route to get it done, but that's what happened behind the scenes to get a lot of that funding.
Well, what ahead of the legislator or the 2013 session was Sandy Hook, and I had lawmakers telling me they've never seen such a bipartisan effort to increase funding for mental health. So that goes to your point of just obviously that one stuck with a lot of people in the headlines, given the victims in that race. Brandon?
This one comes from Hannah in Austin. The high rate of uninsured people in rural Texas is unbelievably high. How can we find the political will to expand Medicaid?
Call your lawmakers.
As he thinks about that one, I'll tell you, unbelievably high rate of uninsured in Texas. That's another category we lead the nation in that you don't want to lead in. So we have top the nation in rural closures. We also top the nation in percent uninsured, and there are 4.5 million uninsured Texans. The number 2 state is Florida, and they have 3.5. So we have 1 million more uninsured Texans than any other state. And I don't think Texas is going to expand Medicaid, but there are things we can do to make progress with regard to supplemental payment programs like the waiver and innovative programs to get more Texans covered.
Or the Republican leaders have talked about a block grant, which is similar to what Joe Ross proposed basically last session.
Similar block grant versus per capita grant. So maybe we can approach that without everybody thinking it's a landmine they're going to step on. But going back to your question about uninsured, it takes political fortitude to go out on a limb on something like that, because it's just going to cost money somewhere, or you're going to have to pass some legislation forcing changes in the current marketplace, and medical insurance companies have a lot of money and a lot of clout in Austin. They can donate to a lot of political races. And then again, it comes down to leadership. What are they going to identify as the priorities? How are they going to get there? So, depends on who you vote for. It depends on who you vote for. And when you get mad enough at the person in that office, and you go vote for somebody else to replace that person.
Thank you.
Could psychology students and social science students be fast-tracked to become mental health providers?
Dr. Flores?
Well, we have explored that option. I think more and more schools are looking into how that can happen. And I'm not sure exactly how to address that, but I know that there's different universities such as TTHSC and others that are looking into how to make that happen.
The Attorney General of Texas is currently party to a suit that seeks to have the courts find the Affordable Care Act or Obamacare unconstitutional. How would repeal of the ACA by the courts affect rural Texans, and what could the state legislature do to protect them should it be overturned?
And the Attorney General just got reelected, didn't he, folks? It's going to be grassroots. And I think you saw some of that this session when not one Democrat seat in the House lost, but 12 Republicans did. And that's a sign that there is a growing rise of discontent with something, and that is one of the issues that the Democrat Party feels strongly about. And evidently so do a lot of voters out there. But that is going to come down to leadership at the highest levels. The governor, lieutenant governor, speaker, attorney general. They can either block it or they can try to work with it. And whichever direction they go pretty much sets the way the House and the Senate will go.
There were several stories, including on the Tribune's website, written in the wake of the race. Of course, statewide leadership remained in the Republicans' hands, but a lot of races were close, and I think it has a lot of Republicans reflecting. Do you expect to see something different along the lines of health care given the results?
Before the election, the feeling in Austin wasn't if the Democrats were going to win. It was how many seats are they going to win and how close are they going to come on other seats. So there is definitely a change in the wind in Austin right now about the political thinking before that election and now after that election. So we'll see what happens in the session.
Definitely be paying attention. We'll leave it on that note. Let's have a hand for our final panel. And with that, that concludes the Texas Tribune's first ever Rural Symposium. Thank you so much for coming, and thanks to our sponsors as well for making it all happen. Safe travels.
Thank you.
Thank you.